cardiology, having headed the smoking cessation program in Changi General Hospital before I left for private practice. And I'm also a trained cardiac rehab practitioner.
Hi, I'm Dr. Tan, Jian Jing. I go by Dr. JJ as well. So I'm a cardiologist that subspecializes in preventive cardiology and cardiac rehabilitation. I also subspecialize in echocardiography, cardiac CT, and also does a cardiopulmonary exercise stress test. So I'm honored to be invited today to share more knowledge with my friends and our audience out here.
The first question that we're going to ask our cardiologist today is, what are some of the first noticeable symptoms of heart disease, especially should not be ignored?
Sure. So let's take a step back. Understanding the heart, so you can see, put it in very simple terms, heart is a pump. To allow this pump to be pumping blood efficiently to send blood and oxygen throughout the rest of the body, this pump must be functioning normally. 3 factors needs to be in place. The first factor is the architecture of the heart, the structure of the heart. Meaning to say in layman's term, is it big or small? What's the pumping power? How's the valves doing? Are they too tight or are they too leaky? Is there any congenital holes in the heart? So the structural issues of the heart can be one kind. Second kind will be the electrical conduction system. Right, some patients with short-circuiting of the electrical conduction will experience palpitations. Some other elderly or diseased heart muscles can also suffer from a reduced conduction. So on the other spectrum will be the needing pacemaker. Then the last factor will be the blood circulation to the heart itself. So our heart doesn't rest. From day one when we are born until the day we go, it doesn't rest. So in order for heart to be pumping efficiently, its own blood supply must be sufficient to meet its demand. Understanding these 3 factors, I repeat, the structure, electrical conduction, and the coronary blood circulation. And then we'll understand how all these symptoms, which I'm going to describe, matter. Right, so the first thing will be the chest pain. All of us would know. Right, chest pain will be an important symptom. Second will be shortness of breath, especially on exertion. Some patients who do not exercise, they do not really feel the breathlessness, even at rest. But for patients who exercise regularly, they will have noticed a reduction of their stamina. In medical terms, we call effort tolerance. In such cases, if there's a reduction in effort tolerance, that can signify a heart disease, or it can also mean other things like lung diseases, but all these are telltale signs. Palpitations, which can signify a electrical conduction issue. Of course, the last one will be fainted, loss of consciousness. If the heart fails to pump, fails to deliver blood out of the chamber into the brain, can be due to a heart failure, weakened muscle or conduction electrical issue, like sudden cardiac death, or even during heart attack. So patients can lose consciousness. So all these are the 4 important symptoms that we need to pay attention to: chest pain, breathlessness, palpitations, and loss of consciousness.
Yes. So heart disease, I think we are referring to coronary artery disease or heart artery blockages. This is very prevalent, and some of the early symptoms that we usually see in patients are those of what we term as exertional symptoms, whereby the patient feels either chest discomfort, breathlessness, or just noticeably more tired with exercise or with activities of daily living. They might find that they have a reduced effort tolerance, meaning to say that they could not do or walk the same distance that they used to do, or cannot climb the same number of flights of stairs as they used to be able to. However, we need to be mindful that some patients might have what we term as atypical or symptoms that are not typical. And this is especially more common in patients such as females or patients with long-standing diabetes, whereby their symptoms can be different from the classical ones that are described in the books. And this can range from things like gastric discomfort, a pressing sensation on the chest, or sometimes they might not even have any chest discomfort, but that of neck, jaw aches, or even shoulder aches that seem to be worsened with exercise. I quote a couple of examples that I've seen recently. I have had a patient who only described a neck pain that was worse with cycling. And true enough, after further evaluation, we found that he had a very tight blockage in one of the arteries, and treatment of this tight blockage led to actually resolution of his symptoms. And in another case, also to demonstrate that symptoms can be very atypical, this was a patient who only had jaw discomfort the day that he presented with an acute heart attack, whereby there was a 100% blockage of the artery that had to be treated emergently.
We've all heard about preventative imaging. Can you share more about it?
Preventative imaging is whereby there's imaging of the heart before the onset of symptoms or onset of a classical disease. And this will include, particularly for when managing heart disease or heart artery blockages, this will include calcium scoring. CT calcium scoring is a modality whereby we scan the heart without any contrast injection. There's no injections, there's no needles. It's just a simple CT scan with a very low radiation dose of the heart to look at how much hardening or calcification of the heart arteries there is. This is a very useful modality because it helps to assess the arteriosclerotic burden of the heart arteries or the amount of blockages that the heart arteries might have. And this can actually be a prompt to do further testing or to actually commence medications that can help retard the progression of heart artery blockages. For example, if a patient went through a calcium score and was found to have already some calcification of the heart arteries, this could be a decision. This could help make a decision, help us make a decision of whether to start cholesterol-lowering medicines earlier rather than later. However, I would also like to point out that calcification of the heart arteries do take time to develop, and heart arteries, when they first begin, they start off as soft plaque, and only over time do they develop calcifications or do they harden. Therefore, I do recommend that calcium scoring is not done at too young age. Usually, I do not recommend it below the age of 40 years old. Firstly, because the a normal calcium score then could be falsely reassuring. And secondly, we are exposing the patient to unnecessary radiation at a younger age. Other forms of preventative imaging that are commonly done, but maybe with less evidence to support their use, will be, for example, carotid intimal medial thickness imaging. This is an ultrasound modality where we scan the thickness of the artery wall of the carotid artery, which is an artery at the neck. This is a very simple test that uses ultrasound. There's no risk involved. It's very useful to. It is useful to prompt further investigations should the patient be found to have a thickened intimal media of the carotid arteries. But however, there can be quite a bit of variation in terms of measurements and assessment by a cardiologist with regards to the results of this test will be useful to guide further management. And perhaps I also like to add that when assessing for cardiovascular risk, when we do preventive imaging or preventive testing, we are actually trying to evaluate cardiovascular disease risk. There are many ways to do this. This includes checking the cholesterol levels. It can include doing something called a high sensitivity C reactive protein blood test. and can also involve other modalities such as ankle brachial index, where you measure the blood pressure of the ankle versus the brachial arteries. However, I would like to point out that amongst all these modalities, CT calcium scoring has been shown to be one of the best in terms of re-stratifying this risk.
We all know that family history plays a big part in our health. What would be the ideal age to start heart screening?
So if we look at our local guidance from the Health Promotion Board, screening should start from the age of 40 years old and tends to be repeated every 1 to 2 years time. And that is for the general population. However, we do know that there are some patients who might be at a higher risk, be it because of a positive family history, or they themselves might have other risk factors such as smoking status, or already known to have abnormal sugar levels. In such patients, they should have screening done at a younger age. Particularly, we do now know that there are patients whereby, or rather there are families whereby their high cholesterol levels tend to be inherited in nature. So for patients who have family members that have very high cholesterol levels, they are likely to be gene related, whereby it tends to be inherited by their family members. Then these patients should have screening done earlier, especially testing their cholesterol levels. And when we say early, I even mean in the childhood ages, because picking up these problems and starting treatment early can reduce the risk of subsequent development of coronary artery disease. On the point of testing for cholesterol, we traditionally test our cholesterol profile or lipid profile that includes the HDL or good cholesterol and the LDL or commonly termed as the bad cholesterol. Lately, in the last 1 to 2 years, there's been a push towards checking lipoprotein A, which is a special cholesterol particle that tends to be genetically determined, is elevated in about 1 in 5 of the population. And checking this can help further guide our management of the patient's cholesterol profile. So actually, for screening of heart disease, it all starts with actually taking a good history. Taking a good history of the patient's lifestyle, whether he's a smoker, his dietary and exercise practices, whether is there a family history of heart disease. Many of us also would ask questions that relates to sleep. We'll be asking about symptoms that might be suggestive of obstructive sleep apnea, because we do know that obstructive sleep apnea is common and is a cardiovascular risk factor. Following that is actually a physical examination, and the next steps will very often be, for example, doing a 12-lead electrocardiogram as a first-line screen. Depending on the age of the patient and his risk factor profile, other screening modalities that can be performed will include a stress ECG or a treadmill test, and like mentioned earlier, a CT calcium score can also be useful to further evaluate the risk of the patient.
Calcium score, picks up calcium in the arteries of the heart. So we talk about calcium scoring, we're referring to the heart. It's one of the cardiac screening tests. Back again to the basic theory, as the plaque accumulates in the artery, during the initial formation, This plaque is soft plaque, or we call non-calcified plaque. It's just being formed. After a year or two, depending on other risk factors, calcium will deposit themselves onto the plaque and highlighting them when you do a calcium score. So a calcium score that is positive will equate to this patient has arteriosclerosis in the artery. In our case, calcium score of the heart means there is plaque in the heart arteries.
Given that calcium deposits build up over time, would you say that we should, because we all need calcium in our day-to-day, does calcium intake, especially when you get older, we want to prevent osteoporosis, should we or do we reduce our calcium intake to prevent this problem, or is it not related?
Okay, fundamentally, we have to understand it is the plaque that is building up. Calcium deposition is a way of highlighting it. So it is not recommended to reduce your calcium intake. It's because having calcium deposition is not the problem. Just that the calcium highlights the problem. It's the plaque that's choking. So a CT calcium score that is 0, right? Does it mean you got no plaque? Answer is no. You can have soft plaque, especially when it's just being formed. Yeah, I've seen patients with calcium score 0, but they've got tight narrowing of the arteries due to a soft plaque, which is a non-calcified plaque.
So, Dr. JJ, would you say that when we sign up for our yearly health screening, the screening of the heart and how well your heart is doing is a very key area to look into?
So when we do cardiac screening, right, we use different tests to look at different aspects, these 3 different aspects. For example, all of us will know ECG, electrocardiogram, looks at the electrical signaling of the heart. Echocardiography, which is ultrasound of the heart, looking at the heart structure. We've heard of treadmill tests, running tests, or even stress imaging. All this look at the supply and demand. Supply of blood, is it able to meet the demand of the heart muscle? So this is to look at the coronary arteries. There are other anatomical tests such as cardiac coronary CT scan, right, CT coronary artery. This will allow us to map out the coronary arteries to see if there's any blockages. So different patients with different risk factors, we are able to score them using algorithms and guidelines. Right, we follow American, European, and also Singapore chapter of Cardiologist guideline to allow us to better tailor different screening tests for different patients.
So, Dr. JJ, we all know that cardiac rehabilitation is very important. A lot of patients who have cardiac surgery usually embark on a course of rehab after. Can you tell us why it is so important and who it is for?
So cardiac rehabilitation essentially is a multidisciplinary program. All right, many patients would misunderstand it, thinking it's just exercise, but it's a multidisciplinary, meaning to say we'll also involve occupational therapists, physiotherapists, nursing counselors, pharmacists, dietitians, and even a medical social worker. So in this multidisciplinary approach, the main aim, all right, apart from providing supervised exercise program to patients, is also to counsel the patient and also to educate them, to empower them with the understanding of cardiac disease and how can we better improve our heart function. The cardiac rehabilitation usually are indicated for patients with coronary artery disease, with or without surgery. It's also indicated for valvular heart disease and even heart failure. So it's not just for patients with post-surgery. In cardiac rehabilitation, there are usually 4 phases. The first phase is inpatient in the hospital. That means when patients are acutely admitted in the hospital, usually 3 to 5 days. We'll start with some physical exercises, simple ones with low intensity. Subsequently, upon discharge, it will still be a hospital-based outpatient supervised exercise program, and all the paramedical individuals will be coming in. The nurses, the therapists, dietitians, pharmacists will be coming in together to provide counseling and also lifestyle changes advice, such as smoking cessation, dietary changes. The pharmacists will be there to answer all the medicine queries. How does different medicine interact with the diet? Doctors will be there to prescribe exercise as well and to titrate their medications. So this is the phase 2, usually outpatient, which lasts around 8 to 12 weeks. Subsequently, when patients complete, all right, they can choose to go to tertiary centers such as Singapore Heart Foundation or private physiotherapy center to allow them to continue supervised exercise program for a period of time ranging from 4 to 8 weeks typically. And of course, we always advocate exercise for life. And phase 4 is where my patients exercise on them by themselves, own time, own target. In cardiac rehabilitation, why is it important? Because statistically has been proven, not just in American and also European guidelines, stating that it can reduce recurrent heart attacks by up to 40% and they reduce mortality. Mortality meaning to say the risk of death by 25%.
So can a patient actually do cardiac rehab at home after the surgery?
Definitely yes. All right. So even though patients are advised to come back during the phase 2, whereby they are stationed outpatient and they'll be given a set of exercise program for them to do at home. Yeah, so cardiac rehab it's unlike signing up gym classes whereby you have to come to the gym to fulfill that 1 hour. Nope. It's really to come down, we'll teach you what to do so that you can continue to do it at home. And even at phase 4, when patients is doing cardiac rehab, own time, own target. Right, so exercise program like a set of aerobic exercises, a set of strength training exercises will be given to patients, right, of varying intensity, can be low, moderate, up to high intensity, depending on individual's condition. Yeah, so it's always advisable for patients to continue exercise, even their medical conditions are stabilized.
So we're looking at a period of, like you said, it's lifelong.
Yes, definitely lifelong. Yes.
Maybe another interesting story to share is that that sometimes patients don't report any symptoms even though they have very severe disease, and that's because they might have reduced the amount of exertion that they do in order to cope with perhaps some of the mild symptoms that they were experiencing before. So for example, I've had a patient who did not actually have any symptoms, but went for screening with a stress ECG or treadmill test that turned out to be strongly positive or strongly abnormal. Further evaluation showed that he had very tight blockages, and I did ask him whether or not he had any symptoms at all before that, and he said no, but actually he has only been, he has not been exercising, he has been walking. And after we treated the blockages, he's now telling me that he actually can go for jogging without any problems, and he feels a lot more energetic compared to previous. So sometimes some patients might not have any symptoms is because they might have sort of self-limited the amount of exertion that they do. So screening definitely is important because it can pick up unknown disease, whereby in such cases, if undetected and untreated, could lead to further complications if not managed early.
Yeah, so I think a healthy lifestyle, and like Dr. JJ also shared, exercising can actually help you to pick up heart issues along the way that you didn't know you actually have.
Yes, that's also true because when you start off exercise, very importantly, watch out for symptoms. If you do encounter any symptoms, then stop. Symptoms of chest pain, breathlessness, or any discomfort, do stop and seek medical attention. I also do recommend that anyone who is planning to start on an exercise program, to start low and really build up the pace slowly. This is going to be a long game. You do not want to, start off very intensively and then injure yourself, and this will stop your exercise journey. But rather, build up the pace gradually. A good guide is actually to exercise up to moderate intensity. And I know that not everybody uses a wearable device and do not monitor their heart rate during exercise. So an easy way to gauge what is moderate intensity is to actually exercise to the point where you have a breath to talk but no breath to sing.
Okay, that's very interesting. Okay, let me put it to you guys. As cardiologists, how much exercise do each of you do a week?
Yeah, I do quite a bit of exercise. And I also do take statins, but I mean that is off-label, yeah, because my cholesterol profile is actually okay. But I do believe there's a current push towards having low cholesterol, lower the better for longer. Meaning to say, having a lower cholesterol at an earlier stage in life in order to reduce the risk of heart artery blockages. But however, I must qualify myself. I must state that this is off-label, and this is my own practice for myself. With regards to exercise, I do quite a bit of exercise. The current recommendations is to do 150 minutes of moderate intensity exercise a week. And that also, so that's about half an hour each time for 5 times a week. And as mentioned earlier, moderate intensity exercise will be exercising to the point where you have breath to talk but no breath to sing. If you do use a heart rate monitor, you can exercise to about 70 to 80% of your predicted maximum heart rate, and whereby the predicted maximum heart rate is calculated as 220 minus your age. The other thing that is important other than doing aerobic exercises is to also focus on strength training or resistance exercises. This is recommended about twice a week. This helps to build up muscle mass, improve your metabolic rate, and actually helps the patient maintain a healthier weight. So personally, I do like to do a long distance running. And I try to do a long run, sometimes even a weekly half marathon.
Well, where do you find the time? Okay, Dr. Gigi, how much exercise do you do?
I'm impressed with Dr. Jason. For myself, I usually swim 3 times a week, 2 hours each for my aerobics, and I go gym twice a week. Yeah.
So, Dr. Jason, what is the one key advice for your patients as a cardiologist, a very important thing you want them to keep in mind for heart health?
I think for me, the key advice is that heart health starts from, it's not just a visit to a cardiologist or to do a screening test, but really starts at home. Starts with what you do on a day-to-day basis. Things that are important will be to not smoke. If you do smoke, do stop smoking. We do know from some studies that even smoking 1 stick a day can have 50% the risk of smoking 1 pack a day. So if you do smoke, stop smoking. Increase the amount of physical activity, meaning to say, be more active. Try to get your 10,000 steps a day if possible. And beyond physical activity is to also do structured exercise. So physical activity is not the same as structured exercise. So structured exercise meaning the 150 minutes a week of moderate intensity aerobic exercises together with twice a week sessions of resistance or strength training. And also focus on a healthy diet. I generally do not try to focus too much on specific food types because it's very hard to follow, but rather just follow the healthy plate model from our health promotion board. I think that would be good enough. Meaning to say, have more fiber. About, if you imagine a plate, 50%, half the plate is fiber, fruits of fiber. 1/4 proteins, more of white meats such as fish, skinless poultry, and then 1/4 carbohydrates. And the next thing that's important with regards to heart health is actually to have good sleep, meaning to say have adequate amount of rest and sleep a day. And things that we can do at home before we even see a doctor or see a cardiologist is to actually monitor your own blood pressure at home. If you do have elevated blood pressure, then do seek further medical attention. With regards to actually all these things that I'm talking about is actually from the American Heart Association's Life Essential 8. So I've spoken about 6 of them. The other two is about keeping an eye on your cholesterol and sugar levels. Those you do need to drop by your GP or your cardiologist or any other doctor that can help you run those tests.
If there's one tip I can give to patients, all right, one single tip I will advocate is to exercise. Why? Because exercise serves two purposes. First, when we can sustain moderate intensity exercise every day, if not minimally 5 days a week, we sustain this for 3 to 4 months. It has been proven to reduce your blood pressure, cholesterol, sugar, potentially even weight. That's the first fold, direct benefits of exercise. The second purpose for exercise is as a monitoring tool. Earlier on I mentioned, if every day I'm able to run 5 km or with minimal breathlessness, suddenly or recently I feel much more breathlessness or feel chest tightness even after 1 to 2 km. So there's a reduction of effort tolerance. Exercise is also enable us to send warning signs. Yeah, so it's a way of monitoring.
Okay, thank you to our cardiologist today for very insightful sharings on how we can all live healthier and maintain our heart health. So thanks for joining us today.
Thank you very much. Thank you for the invite.
Thank you.
Okay, look out for our upcoming podcast next month where we'll be speaking to our doctors on breast cancer.